We shall now go on to our next young dynamic speaker, Dr. DEWANG ANGMO, who is Assistant Professor of Ophthalmology for glaucoma, strabismology, and neuro-ophthalmology services at RP Center, and she is going to tell us about early bleb leaks. On to you.
Thank you, ma'am, for the kind introduction. At the outset, I would like to thank the organizers for inviting me, and I would be speaking on management of early bleb leak. So if you, in the early post-operative period, what we look for after doing a trabeculectomy is to check for the IOP and look at the anterior chamber depth. And we have to rule out a leaking bleb by doing a Siegel's test. So this is the first thing that we look for. So early bleb leaks are not uncommon. The leaks, the incidence ranges between 0 to 30%, depending on the, more so with the fornix-based flaps versus the limbal-based flaps. And we always have to do a Siegel's test or a pressure Siegel's to look for a leak, to note the wound gape or any buttonholing. And also we should know the risk factors for these early leaks. Usually these patients are usually high myopics, or patients having connective tissue disorders, or patients of extreme ages, old ages, who have thin flimsy conjunctiva, who are likely to have these defects. So along with these leaks, what is common is that we have some grade of shallow anterior chamber. So the anterior chamber depth should also be noted along with the leaking blebs. So if you look onto a working management of the early bleb leak, is that if the leak on the Siegel's is, if the defect is less than 1 mm, and on Siegel's the leak is not profuse, then we should go ahead, do a conservative management, wherein we have medical management, we have pressure bandage, and we rarely do use glue. And if the defects are more than 1 mm, we should go ahead and do a surgical repair. So if you look at the management, in the medical management, the first thing that we should do is to taper the steroids, which will enhance the fibrosis. We can also use pressure patching or pressure bandage, a large diameter bandage contact lens, and aqueous like topical beta blockers, which will depress the aqueous circulation and enhance the fibrosis. So this was a patient who had an early pinpoint leak, as we can note at the arrow, where there was a suture tract leak. So in this patient, we managed the patient by a conservative management, and we also gave a oral tablet doxycycline, which also enhances the conjunctival epithelization. And within a week, this suture tract leak healed on its own, and the anterior chamber was maintained. You can also do a pressure patching, which classically they use two bandages for the pressure patching. And this also works very well in the early postoperative period. In the large diameter bandage contact lenses, especially can be used if it is a limbal based flaps, and where the small defect is at the limbus, where it cannot be sutured, and it works wonderfully in these patients. However, on the other side, if we see a profuse leak and the defect is more than 1 mm, these blebs are unlikely to heal on its own, and a surgical repair is more so required. And along with that, AC repair may or may not be required. So during a surgical repair, these patients, we prefer to do it under a peribulbar block. However, these eyes may be severely hypotenuse, and therefore subtenon lignocaine can be given on table, and we avoid toothed forceps, we avoid cutting needles, and preferably do a good exposure of the bleb using corneal traction sutures. And even after all these conservative management, our bleb does not, the leak does not stop, or the bleb doesn't heal, we should always do a wound exploration. So this was a case in which there was a persistent leak, and we were managing it for with conservative management for a week. However, when we did a bleb exploration, we could see that there was a gape at the temporal side of the wound, and the wound margin was ragged, and it had extended anteriorly, which was leading to a persistent leak. Herein we had to suture the flap, and thereafter we had to do a watertight closure of the conjunctiva using a round-bodied tapered needle with atovicryl. On the other hand, if there's a large defect which is more than 1 mm, we can either do a conjunctival advancement or a conjunctival patch graft or a scleral patch graft with conjunctival advancement. The videos, I think, would be overlapping as with that of Dr. Gauri. And in the interest of time, I would just like to summarize that for early bleb leaks, after doing a Seedles, we should first check for the defect. If it is on the smaller side, less than 1 mm, we should do a conservative management. However, if the defect is on the larger side, a surgical repair is required. Thank you for the patient listening.
Thank you, Dr. Dewang. That was a very crisp talk which seemed to cover everything. But something very basic which the audience would want to know too is, how do you avoid suture-related suture tract leaks? Dr. Shushmita?
Yeah, sorry, what? How do we avoid?
Suture tract created leaks.
One thing is, when you're especially doing conjunctival flaps, I think it's important to use a round bodied needle, because the width of the needle is equivalent to or slightly more than the width of the suture. Whereas if you use a tapered point, then there would be a suture leak and a tract formed. But having said that, since most of us are doing phonics based flaps now, so we do need tapered needles, but it's important to include the episclera when we are suturing conjunctiva, especially if you're doing wing sutures. But in case you're doing a frill suture and you're doing conjunctiva to conjunctiva, I think having a A-toe round bodied is important rather than that. That's the most important thing.
Now, if the leak is a little beyond the limbus, wherein the contact lens may not work, so that means in those areas we are left with a surgical repair only, I suppose.
Yes, if the contact lens, even if the leak is within the area of the contact lens, we generally give a conservative treatment for just 2-3 days. And another thing to do is we can give aqueous suppressants to reduce the aqueous production for that period of time, so that there is no aqueous being produced when the leak is healing. That is one. But if not, I mean, it's foolhardy to wait if you've seen a leak and you haven't repaired it. So you really want to go and repair it as soon as possible.
Anybody in the panel have any question to ask, or Murli, you have anything which you should cover?
Yeah, I would like to ask the panel, if you opt for a large diameter contact lens, then how long would you keep the contact lens in place, and when would you like to remove, if the anterior chamber has deepened, and so when would you like to remove the contact lens and check again for the leak?
So we usually use an extended use of contact lens, which can be in place for at least 48 hours. So we would do that, allow time for it to heal before even attempting. There's no point removing it immediately. But sometimes the 16 mm contact lenses are very difficult to acquire. You may not get it offhand. The tip about pressure bandage is that we do not keep the pressure bandage on if the patient is asleep. So our instructions are that do not have the pressure bandage on when you're sleeping, because then with the bells, you're actually compressing the center of the cornea and all of that is gone. So we tell them that if you're feeling very sleepy, just take off the pressure bandage and sleep, but have it on throughout the day. And very small leaks, and if the pressure is still, if the chamber is still about grade 2 and still not flat, they might just heal with steroids, atropine, and a pressure patch. You don't even need to put in a contact lens.
Yes.
So what is the time you typically check for the leak? Do you check on the first postoperative day or the 9th day when it is set to peak? And how long do you keep checking for the leak? Does the bleb morphology have anything to do with it, or do we do it routinely in all patients for the first 3 weeks?
No, there has to be a reason to check for a leak. There has to be a hypotony, flat, shallow AC, and a flat bleb. That would be the most important. So if I can obviously see an overfiltering bleb with a shallow AC, I know that there's not leaking. So the bleb morphology would. So routinely we would. But yes, if you have a dysesthetic bleb, if there's hypotony, and if the AC is shallow with a bleb which is not so well formed, those are the red herrings. Those patients should do a leak check.
Very true. I think that